Good day, everyone. I am Angela Shanin Capilio, and I am with Miss Amna Hanif, Miss Bea Pili, and Mr. Jeffrey Timkang. And today we are going to talk about how much saliva is enough for avoidance of xerostomia. So let me start by defining what xerostomia is. Xerostomia is the subjective sensation of dry mouth occurs when the salivary flow rate is less than the rate of fluid loss from the mouth by evaporation and by absorption of water through the oral mucosa. Xerostomia is not a disease, but it may be a symptom of various medical conditions, a side effect of radiation to the head and neck, or a side effect of a wide variety of medications. It may or may not be associated with decreased salivary gland function. Only mouth breathing causes evaporation, which can reach a maximum rate of 0.21 milliliter per minute at rest, though it is typically much lower. On the other hand, water absorption through the mucosa is possible because saliva has one-sixth the osmotic pressure of extracellular fluid, resulting in a water gradient across the mucosa. The maximum absorption rate is estimated to be 0.19 milliliter per minute, with the rate dropping to zero when the saliva becomes isotonic. A recent study found the residual saliva volume to be 71% of normal in patients with severe hyposalivation and whose mouth felt very dry. So this is the total volume of the saliva left in the mouth after swallowing. Saliva is present in the residual volume as a thin coating that varies in thickness depending on the location. Hard palate has the thinnest film, and when the hard palate reaches about less than 10 micrometer thick, it may result in reduced evaporation during mouth breathing and fluid absorption into zero, causing xerostomia. Reduced secretion from the soft palate minor glands is also usually associated with this, which may contribute to the film on the hard palate. Thus, xerostomia appears to be caused by localized areas of mucosal dryness, particularly in the palate, rather than a total absence of oral fluid. Unstimulated salivary flow rates greater than 0.1 to 0.3 milliliter per minute may be necessary for this condition to be avoided. It is important to distinguish between xerostomia and hyposalivation when choosing how much saliva is necessary to avoid the sensation of dry mouth. As I said a while ago, xerostomia is the subjective sensation of dry mouth, whereas salivary hyposalivation is the condition of having reduced saliva production, which is different from xerostomia. And the best way to diagnose hyposalivation is to measure the salivary flow. Patients with low salivary flow may experience many problems, which include xerostomia, increase in caries, particularly at sites where caries are not typically seen, such as the incisal edges. Reduced clearance of bacteria and food, resulting to gingivitis, soreness, fissuring of the tongue, cheilitis, and infection of salivary ducts. Another problem is recurrent yeast infections. A bacteria known as Candida causes most yeast infections. Lack of regular hygiene practices such as daily showers and brushing your teeth or a constantly damp environment can also lead to yeast infections. Difficulty in chewing, speaking, and swallowing, increased frequency of calculus deposition in the salivary ducts, burning mouth, and difficulty in retention of dentures. According to DOS, the whole unstimulated saliva flow rate is approximately 0.3 milliliter per minute. However, in one research of Bex and Wainwright, There are 661 seemingly healthy persons who did not complain of xerostomia. The range was 0.008 to 1.85 milliliter per minute. So clearly, the adequate flow rate of saliva obviously varies from person to person. Shribny et al. And others regard an unstimulated salivary flow rate of less than zero point 0.1 milliliter per minute as evidence of hyposalivation and less than zero point 0.5 milliliter per minute in response to the chewing of paraffin wax. Salivary flow is typically stimulated by food consumption, and an insufficient flow during meals might make swallowing dry foods difficult. Fluid balance in the mouth. Fluid enters the mouth from the ducts of various salivary glands, while fluid loss may occur by swallowing, by evaporation, or by absorption through the oral mucosa. The rate of fluid intake usually exceeds the rate of fluid loss through evaporation or absorption through the oral mucosa, and the excess is swallowed on a regular basis. The mean volume of saliva in the mouth is 1.07 milliliter, range 0.52 to 2.14 milliliter prior to swallowing. Maximum volume to a mean of 0.77 milliliter, range 0.38 to 1.73 milliliter after swallowing, which is the residual volume. When flow is unstimulated, the volume of saliva swallowed is about 0.3 milliliter with each swallow. So the swallowing frequency will be around once per minute if the unstimulated flow rate is 0.3 milliliter per minute. When the salivary flow rate is reduced, the frequency of swallowing decreases, although it is unknown if the residual volume changes during sleep. If evaporation of saliva and fluid absorption through the oral mucosa did not occur, it is reasonable to assume that anyone with even a low saliva flow rate would not experience xerostomia because the residual volume would remain constant. The residual volume would be expected to decrease if the rates of fluid loss through evaporation of saliva and absorption of fluid via the oral mucosa are greater than the unstimulated salivary flow rate. However, it would be temporarily increased if flow was unstimulated.
So the next thing that we will discuss is the rate of water evaporation from the mouth. So during our primary school days, this kind of topic has been discussed, and it has been taught to us that evaporation itself is known as the process of water that will change from a liquid state or the water itself to become a gaseous state, or also known as the water vapor. So the rate of water evaporation from the saliva will be influenced by the respiratory minute volume with mouth breathing. It has a percentage of the inspired air that will pass through the mouth and its temperature and relative humidity of the inspired air. So it means that when we breathe and our mouth is open, there's possibly an evaporation of water from the saliva that might happen, which can cause of dry mouth. So Proctor 1977 has reported that the air inspired through the nose will almost become saturated with water vapor and will reach its temperature for about 33 degrees Celsius. So even when the ambient temperature will reach about negative 20 degrees Celsius and the inspired air is heated about 27 degrees Celsius by the time it reaches the nasopharynx. And next is according to Neenima et al. 1981, the proportion of the population who are mouth breathers is around 10 to 15%. And in such persons, about 50% of the inspired air passes through the mouth. And it was not expected since the common bind across sectional area of the nasal passages on the posterior to the nostrils is only about 60 mm squared, according to Proctor 1986. So next slide, please. So next is according to Kamner and Bach, during normal conversation by non-mouth breathers, there is more than half of the inspired air that passes through the mouth. And then the respiratory minute volume at rest is about 6 liter per minute, according to Gannon 1999. And that air at 33 degrees Celsius and about 100% relative humidity contains 35.68 grams of water per minute cube. And then it has the maximum rate of water evaporation from the saliva into inspired air that was initially dry, and it would be as high as 0.21 ml per minute in complete mouth breathers. So the xerostomia has received a little attention on its involvement in the saliva evaporation because of its connection, although it is well known that certain animals such as dogs uses water evaporation from the tongue in place of sweat as mean of their body temperature control. And since saliva evaporation is one of the cause of dry mouth, this is where xerostomia will take place, and it will lead to some mouth diseases, just like some painful periodontal disease. Next slide, please. So next is the rate of water absorption through the oral mucosa. So the permeability of the oral mucosa can be characterized by a permeability coefficient. So, yan ang where the Q or molecular is the quantity of ferment crossing the epithelium. And then next is yung A, which is cm squared, is the area of the tissue. And then the CO and CI, or the molecular per liter, are the concentrations of the ferment on the outside and inside of the mucosa. And lastly, the T, which means time or minute. So there are actually some few studies of permeability to water of human oral mucosa and autopsy specimens that has been employed with tritated water as the ferment. Of the advantages of tritated water is that it has concentrations on the one side of the mucosa. So the unstimulated saliva has an osmotic pressure that is about 1/6 of the extracellular fluid. Thus, there is normally a concentration gradient for the water to pass from saliva through the oral mucosa. And then its concentration of the salivary electrocytes will increase in time if the saliva will not continue to be replenished. And the net rate of diffusion of water would also fall exponentially and cease when the saliva was isotonic with extracellular fluid. Next slide, please. So for the calculations of the maximum rate of water transfer across the oral mucosa, calculating the difference in the molar concentrations of water and saliva in extracellular fluid is necessary. So the extracellular fluid is isotonic, with 0.9% of sodium chloride. Next is unstimulated whole saliva is also isotonic with 0.15% of sodium chloride. And the next is molarities of water in extracellular fluid and saliva must be about the same as those in two salt solutions. Next, please. So we're still on the topic of rate of water absorption through the oral mucosa. And according to Western Isle, the water's molecular weight is about 18.0.153, and the densities of 0.9 and 0.15% of sodium chloride at 20 degrees Celsius are 1.0046 and 0.9993. So the sodium chloride solution that is 0.9% contains 991 grams of water in 1,000 grams of solution. So when converting the 1,000 grams to ml, division by the density gives 995.421 ml. So the molarity of water in extracellular fluid is 55.0088 by 1000 divided by 995.421. So its final answer will be 55.2618 molecular per liter. And next is, according to Collins and Dawes, the surface area of the oral mucosa averages about 178 cm squared. And then the maximum rate of water transfer from saliva across the oral mucosa will be 4.8 by 10 negative 4 cm per minute, and then multiplied by 178 cm squared, and then multiply again to 0.124 molecular per liter. So the answer will be 0.0106 molecular per minute, or 0.19 ml per minute. Next slide, please. So next is, these are the uncertainties during this calculation in the Kp value. So first is, it was derived at room temperature rather than the mouth temperature. And then the second is for tridated water rather than H2O. And then it was measured on autopsy mucosa rather than on a fresh mucosa. And lastly, it is for ventral tongue mucosa rather than being a weighted over average of all sites. Next slide, please. So there is this computer simulation, which is iterative 1-second intervals, which shows that the normal residual volume would take less than 6 minutes to reach to 95% of isotonicity if there's no further saliva that will enter the mouth. So although water would be expected to pass across the mucosa in the mouth when the mucosal epithelium is dry, so this goes not seem to occur. So possibly because of the distortion of the epithelial cells by the drying obliterates the water channel normally present. So next slide, please.
So saliva as a thin film by Collins and Dawes measured the surface area of the mouth that is found to be about 214.7 plus 12.9 centimeters square. So um, so from this, it basically shows that the surface area of the mouth is basically measured to calculate the average thickness of how much saliva film, salivary film, which separates the opposing layers of the oral mucosa and which also overlies the dental plaque. And this separates the area which is considered where the teeth is found, the palate, the buccal and lingual gingival, and alveolar mucosa, which includes the floor of the mouth and the dorsum of the tongue and etc. So next is the so from the values for residual volume, which is determined by Langer-Loff and Dawes, they calculated that the saliva were evenly distributed to the mouth, so it would be present as a thin film, varying from 72 to 100 micrometer in thickness after and before swallowing, respectively. So basically, it shows that when the film varies in thickness, being thickest to the posterior of the tongue, it shows that when people experience dry mouth, the film of the hard palate becomes thinner to 100 to 10 um, milliliter. And when salivary flow is unstimulated, it varies about 10 folds in different regions of the mouth. Next, please. So this calculation assumes that the opposing surfaces in the mouth, such as the palate and the dorsum of the tongue, are in contact with each other except for the interposition of the fluid film. D. Sapto, Moore-Darcy, and Klenberg found that the marked site-specific variation in the thickness of the surface fluid layer of the oral mucosa, with mean values ranging from 70 micrometer on the posterior dorsum of the tongue to 10 micrometer on the hard palate. Which shows that the unstimulated flow of the rate basically is by 0.3 to 0.4 milliliter. This rate decreases to 0.1 milliliter during while we sleep, and it also increases to about 4 to 5 milliliter during eating or chewing and other stimulating activities. So we should know that saliva is always hypotonic. And so the maximum film thickness in the embrasures and occlusal fissures are usually larger, which shows larger values, but the rate of the fluid turnover in these sites are very uncertain. Next, please. So patients with or without a dry mouth and unstimulated flow shows about 10 to 1 milliliter. That means mucosal fluid thickness were 27.8 and 41.8 micrometers. So in those with dry mouth, the hard palate and the lips has the lowest fluid thickness and values at least 10 micrometers on the palate appeared necessary to avoid complaints of of the dry mouth. Next, please. So the importance of the palatal mucus glands secretion. It shows retentions on the upper denture then of the dry mouth, and burning mouth syndrome are likely to occur when the flow rates from these glands are less than 6 microliters centimeter square of the palatal mucosa. And in person not wearing dentures, these secretion probably also contribute to the film of the saliva covering the mucosa of the hard palate.
So as what you have heard earlier about the analysis of fluid balance in the mouth, this reveals an important conclusion. It is commonly used methods for, for measuring the flow rate of whole saliva do not account for the total fluid output by the various salivary glands. Rather, they calculate the net output of saliva after adjusting for fluid loss due to evaporation and or mucosal absorption. The fact that patients with a low salivary flow rate usually have a dry mouth rather than maintaining a normal residual volume and swallowing less frequently suggests that these latter two processes are clinically significant. Next, please. So the mean residual volume was found to be reduced by 29% in patients with severe hyposalivation. As mentioned earlier, hyposalivation is the objective finding of a reduced salivary flow rate. Also, a very dry mouth in a recent study by Dowes and Odlum in the year 2004. This, along with Kleinberg and colleagues' research, demonstrates that such patients do not have a complete lack of oral fluid. It emphasizes the potential significance of localized areas of dryness in the mouth, particularly on the hard palate. For the xerostomia condition, the palatal minor salivary glands appear to be especially important for producing an adherent fluid film on the hard palate. The latter site and anterior dorsum of the tongue are where xerostomia symptoms are most pronounced. According to Wolf and Klinberg, if the thickness of the film is less than 10 micrometer, the fluid will be very susceptible to removal during mouth breathing by absorption and evaporation, as the palate and anterior dorsum of the tongue will be the main areas to receive initial contact with the inspired air. Next, please. Non-pharmacological methods for the dry mouth patient to reduce the severity of the condition include staying hydrated to maintain maximum unstimulated salivary flow, avoiding mouth breathing as much as possible to reduce evaporation of saliva, using a humidifier to increase a relative humidity during the winter months, particularly in the bedroom, because mouth breathing commonly occurs during sleep, and avoiding tobacco, caffeine, and alcohol to reduce their drying odors. To stimulate salivary flow, use sugar-free chewing gum or candy, as well as water or salivary substitutes. Next, please. So according to Brennan, while several clinical trials suggest that pilocarpine, a drug that stimulates salivary flow, is effective in relieving dry mouth in some patients, and it is also has some negative side effects. As stated by Ja, transferring one submandibular gland to the submental region to shield it from the radiation is a recently developed preventive measure for patients about to receive radiation treatment for cancer of the pharynx or larynx. Over 60 patients in Canada have received this treatment, which maintains flow from at least one major salivary gland so far. Interestingly, the transferred gland appears to undergo hypertrophy in a similar way to residual rat salivary glands after selective desalivation as reported by Swartz and Shaw. Next, please. So in conclusion, if the flow rate of saliva exceeds the rate of fluid loss by mucosal absorption and evaporation, saliva is probably enough to prevent xerostomia. In practice, an unstimulated flow rate of at least 0.1 to 0.3 millimeter per minute is required. Because of an increase in the survival rate for patients with head and neck cancer, as well as an increase in the elderly population, there is a greater need for additional research on the alleviation of xerostomia and treatment of the condition's negative effects. Next. And this will be the end of our report. Thank you.